Tonight. You and I have
You're welcome.
spoken a little bit about what the goal of tonight is just to have a conversation. It's kind of a digital campfire of sorts where we're just sitting around having a conversation about various topics within dentistry. This is session number 35. We've been doing this for over a year now.
Hmm.
And we've covered everything from how to deal with angry patients to how to bond a composite restoration, which was a more recent conversation. So you and I have, we've been working together for years, but really kind of ramped up our collaboration for a multitude of reasons. And, you've really brought something special to our practice. I think all of the doctors are absolutely enamored by your work and your execution to things, and it's made our life easier. I was able to work with a couple of the doctors today on some full arch stuff, some complete dentures, and what you produce just makes our work easier and more predictable, and that is the whole point. We we kind of have grown frustrated with the consolidation of the dental labs that are out there because of the fact that we don't work with the same person each and every time.
Hmm.
So
Hmm.
part of this is thank you, and the other part of this is I don't want to share you with too many offices because we benefit greatly from your expertise, and you're a one person operation, and that's why we get the consistency we get from you. So thank you for everything. But
Well,
tonight,
thank you. Thank you. Thank you.
yeah, so tonight is really just a conversation about partials. Um, I think this particular topic has seemed to have really kind of lost its steam in the dental school education. And I was having a conversation with one of my mentors recently where we were discussing why that is. He brought up the very obvious point that if we have 4 years of dental school training, but now we have implants, we have 3D printing, we have Invisalign, these are things that have to push something out. And that something is the old classical approaches such as partials and dentures. With that said, our patients still need this technology. Just because it's not new doesn't mean it's not necessarily relevant. The downside to this is we're not getting trained very well in school, and partials in particular. Dentures, all removable is difficult, but partials in particular,
Hmm.
man, that's an art. It's a technology. It's a very convoluted thing that I think we need to get to the bottom of. And today, what I'm hoping to do is have a conversation, maybe not how to do a partial, but things to look out for, conversations to have with your lab technicians, considerations to make with certain patients. How to select patients for partials is probably the thing that I still struggle with today.
Hmm.
Something I want to get better at. So, Veronica, I'm gonna share this, and I'll ask you questions as we go along. At the same
Sure.
time, feel free to chime in, and then at the
All
end,
right.
we'll just kind of keep it open forum. If you have anything that you see on your end as a
Hmm.
lab technician that might be beneficial for the group. So let
Sure.
me see here. I'll go ahead and share my screen. All right, Chad, you're out there somewhere. We good?
Good.
All righty. All right, so I started putting the subject codes. Julie is on the call today. She's our um, CEU credit submitter. So if you would like a 1 hour credit for this, if you're on the call and you have your camera on, she does check. If you don't want the credits and you're just here to learn a little bit, that's fine too. There are no expectations, but if you do want the CE credits, the AGD does require that I have some sort of process and system in place to make sure that you're not just turning the camera on, um, playing Black Ops with a black screen, and then going to watch Wheel of Fortune and Jeopardy. So, subject code 6782, and here we have Veronica Krakova, certified dental technician here in Portland, Maine. So, when is a partial a good idea? I'm just going to jump right into it. And the cost is the most important part of this. And I think back to a time when I was doing some treatment planning for a patient, and he said something that really drove a point home for me, and I hope to articulate that here today. And it's the fact that in their patients' minds, when they're choosing a partial, for a lot of these patients, it's a lot of money. And they think they're getting the quality of the outcome of a full implant supported prosthesis or a really highly executed crown and bridge case. In other words, they don't know. we have to drive the point home to patients. And maybe everybody does this, so just kind of let me do my soapboxy thing for a second. We have to make sure that we educate the patients that this is an option for low cost only. Yes, there are some really good partials out there. We're going to talk about how to do a really good partial. With that said, it's not the ideal option most of the time. So when is a partial a good idea? When the financial considerations are the priority. When it's part of a phased treatment plan, not every patient has $45,000 sitting in their bank account to execute a comprehensive dental treatment plan, but maybe they can do it in a phased manner. And that's something we do a lot of at the practice. I have several cases that are going on 5, 6, 7 years now for a multitude of different reasons, but the partials play a really good role in getting a patient from point A to point B to point C, so on and so forth. Partial is a good idea, and we're going to go over this in quite a bit of detail, when the teeth have been properly evaluated, modified, so on and so forth. What I'm getting at here is I myself went to a very pros-heavy dental school, went to a residency with a very strong pros component. And when I got out in the real world, I did for many years what many of us currently do, and I'm hoping to kind of steer the ship in a different direction, where you just take an impression and send it to the lab and say, please make me a partial. This happens all the time, and I'm hoping that we can create some processes and some systems to slow down a little bit and do a lot more in the treatment planning of a partial after we've decided that the partial is the best option. Partial is also a good idea when the patient fully understands what they're getting. Again, this comes back to the story I was sharing in the first line. That patient that really had no idea that what he was buying had so many limitations. And what he said to me was, I thought I was getting the Cadillac when you told me the cost of a partial for a full arch at the time was $1,800. That was a lot of money for him. He probably hadn't spent $1,800 on anything in his recent life, but here I am giving him something, and in my brain I'm thinking this is about as entry level of an option as it gets, but in the patient's mind it should be really good. So setting expectations, aligning expectations is absolutely critical. So don't proceed with a partial until the patient fully understands what they're getting at. And we're going to talk about a consent form at the end of this presentation. Bisphosphonates, something to consider. The patient can't have surgery, can't have implants. Partials might be a good idea under those circumstances. So when is a partial a bad idea? High caries risk. Very obvious. But as somebody who is now spending some time in some more remote practices where the patient demographic is much older, I'm seeing a lot of patients in their 70s, 80s, and 90s. I can't help but really kind of get discouraged when I see a patient on their 5th or 6th partial in 10 years, 12 years. In reality, I don't think that patient necessarily was under the tutelage of a dentist that was really trying to manage the reason why they needed a partial. They just kept kind of repeating the same thing over and over again. So adjusting treatment recommendations based upon certain disease conditions is definitely an important part of this. Again, super obvious, but we get in the thick of a busy day and these things don't seem so obvious anymore. Obviously, high aesthetic demands, partials probably not the best. There are some partials that are more aesthetic than others, and there's ways to adjust for this. But if a patient wants something that's very aesthetic, we might want to steer them in a different direction. High patient expectations. Again, coming back to that D personality, and we'll talk about disc profiling shortly. The D patient tends to be the patient that causes the most amount of brain damage when trying to execute a partial denture. So patient selection is everything. Certain designs, the gag reflex can be relevant. Obviously, with partials, we can do things to mitigate this. With that said, it is a consideration. Again, D personalities. So the Kennedy classification, although somewhat academic in its utility, helps us to have conversations with each other when we're talking about partials. Not all partials are created equal, but also the foundations at which the partials sit in are not created equal. So class 1, class 2, class 3, and class 4, and again, there's modifications on other classes for us to discuss, but these are the high-level classifications that give us a sense of what is the partial doing? What are the rotations of access? Do I need indirect retention? All of these things are very important. If we just take an impression and send it to the lab, how do we know that the lab technician on the other end is as skilled as Veronica is? Veronica has somebody that she works with, and I'd love to hear her partnership, that does a lot of her designs and the metal work, because she understands that the metal framework for a well-designed partial requires somebody with the skills and expertise like the person that she works with, and we'll talk about that shortly. This slide is a little bit out of sequence, but it's a very important part of what we do on a day-to-day basis, and it's when we have to make a crown underneath an existing partial. I'll tell you what, I'm going to come back to this. This is an area of the practice that has become relevant 3 times in the past month, so it's a very common clinical situation that really needs a solid solution.
Can I interject something in that?
Sure.
So I would say, because you have a scanner
Yep.
in your office, in most of our laboratories, all your dentists know how to scan. If you have a scanner, I worked with other offices on the same issue as you're presenting here, fabricating a crown after a framework has been made, and all they do is really good scan of the partial, the prep, and then they send me their digital file, and we fabricate a crown for that underneath.
Okay.
So
That's a new method for that.
uh,
Let's table that because I have a separate slide for it. That is a method I didn't know we could do, so I can't wait to hear about it. But this particular video from Glidewell, it was about that topic, but I really liked what Mike Totola, the guy who used to do all of their clinical videos, said. This particular partial didn't fit on the model from the standpoint that when this partial was sitting on a crown in the patient's mouth, it was engaged. But there's nothing holding this partial in place after the tooth is prepped. So his point was that when the pickup impression was done, this whole thing moved. So in reality, this model was poured up with this particular rest seat not on the tooth because the partial wasn't on the tooth when they took the impression. The point I'm trying to make here is partial dentures require a very high level of cognitive thought. When we're doing fillings, it's like we look at the x-ray and we dig until it's gone and then we fill it. And I'm simplifying the process dramatically. But I think partials, we really have to think. And I think that's one of the takeaway messages here is that when we're doing partials for things like this, we have to think about it. So the solution he had come up with is just taking some composite and bonding this little rest seat onto this tooth, not etching the tooth, but just fixing it in place while the impression is being made so that this doesn't move. These kinds of things happen all the time in removable prosthodontics. We get the case back, and here's what most dentists say. The lab screwed up. The lab screwed up. The lab screwed up. 9 times out of 10, the lab did exactly what they were given, and they executed it to the best of their abilities. But a lot of times it's because there was no thought put in on the dentist's end. And it's not about pointing fingers, but it's about understanding what kind of cognitive thought is required for certain parts of our profession. And I think partial dentures is one of those arenas where we really have to think. So I'm going to skip over these a little bit. These are all from a different...
I also think that also happens a lot when the dentist lets their assistants who are not so experienced take the impression over an unseated partial.
Sure.
Nobody checks it after. It comes to me, for example, or another lab. I'm just talking about myself now. And then you pour the impression and you find that exactly that's what happened.
Sure.
But if it's an old partial, like in this instance, okay, you can probably see that it's not seated properly, but a lot of the old partials don't fit anyway to the patient. So it's really hard to guess, is it really seated like this? Or has it not been properly seated and then impression taken over the improperly seated denture or partial? So those are some of the things to take into consideration as well.
Yeah, are there any tips or tricks that you have to stabilize it? I guess as I'm asking the question, if a partial isn't stable,
Mm,
then is it worthy of a pickup impression? Because a pickup impression is designed to maintain the metal framework, which is providing the positive seat. But if it's not staying up, in this case here, it's not staying up because there's a reason, and that reason is the crown that was prepped.
right,
But there are
right.
many times where the partial's not fitting well and a pickup
Mhm.
impression is being taken. At that point, do you think it's time to maybe reconsider and consider a new framework?
Yes, I mean, you can definitely try taking an impression without a partial in, but the problem then becomes if the partial is already loose or not fitting properly in a patient's mouth, how are we going to know in a lab where where the partial is properly fitting onto that model? I mean,
Right.
we can work with it and we can adjust it and tweak it and seat it, but it's hard for us to know unless I'm with you chairside to
Sure.
assess the situation, which it's tricky.
Sure.
So, and yes, to answer that question, if it's an old partial and not seating properly, like in this case, I don't know how old this partial is, but you're almost better off making the patient a new crown and then afterwards making a new properly fitting framework.
Sure.
I mean, that's ideal. Not every patient wants to do that. Not every patient can afford it. So it's again, it's you know
Sure.
very peculiar field as in any other case.
Veronica, do you also find that, I'm thinking about the difference between a pickup impression and an impression of the underlying situation, the underlying teeth and tissues, and then the partial being put on that solid model. I find it challenging. With pickup impression, the model is poured up with the prosthesis in place, so it's going to fit on that model because the model was poured up to it.
Exactly.
Do you find that there's a challenge when you're using an existing partial to a stone model? Because the stone model doesn't have give, it doesn't have the biological movement.
It can be, but usually it's a slight adjustment that you can see where the partial's fitting in most places, in the key places. If anything, it may be a little tricky on a soft tissue, on a hard tissue, on a palate or something like that. But then that's an easy adjustment on a model where I know the difference between soft tissue and hard tissue in a patient's mouth, and so I can adjust accordingly if I have to.
Sure.
I think you were talking about possibly doing the intaglio impression with a vinyl material and then seating it in the patient's mouth and then doing a pickup impression over that. But that's not the case, right? You were not meant.
Right.
Okay.
Well, that method we'll talk about shortly. But I think the idea of understanding that if a partial doesn't fit, the framework really should be considered to be replaced.
Because it's going to cost ultimately more money to the patient and more challenges for you as a dentist, more chair time, and you're married to this patient forever, and
Sure.
everybody's losing money at the end of the day. You are, the patient is, and that comes with years of experience, maybe for you guys
Sure.
to that point, and nobody wants to disappoint the patient and send them sad home, and so it's
Yeah, back in my early career, so again, I went to a very pros focused, removable pros focused dental school and residency. For the first few years after that, I was pretty much using the protocols and systems that I had been taught. I was using a surveyor, I was getting a custom tray, I was doing all of the steps exactly like you would see in a textbook. And then over time, I got tired of being the only person that was doing all of these quote unquote stupid steps. Fast forward a couple of years, and I started realizing that I was spending so much time adjusting and remaking partial dentures. I must have lost, I mean, I'd love to do the analysis of the time and money that was lost because I got sloppy with my steps. And that's one of the reasons I'm putting this up here. And, I'll be the first to admit that I'm human. And when you see 9 out of 10 dentists not using a surveyor, you can't help but think a surveyor is just a antiquated piece of technology. But in reality, there is a very, very solid body of evidence in the world of how to do a partial well because we've been doing it for so long. compare that to implants. We know how to do implants okay, but 30 years from now, the systems and how we do dental implants are going to be very different. Partials have been around for, hundreds of years. We think of George Washington having his wooden teeth. For all intents and purposes, the technology has been worked out for a long period of time. So, what I'm saying is the fundamental principles of removable prosthodontics, especially when it comes to partials, are rarely done in a general dental practice. So, Veronica, you work with prosthodontists, high-end general dental practitioners, but over the years, I'm sure you've worked with the average GP. I don't want to say substandard, but the average GP.
Mm-hmm.
Do you think that there's a big difference between properly treatment planning a partial? And we're going to start that conversation by the use of a surveyor, but properly treatment planning meaning doing the design on the cast before the final impression is taken.
Yes, so so prosthodontic associates, for example, they pretty much do all of this by the book, the step with the custom tray, and everything. So when you start with the basic alginate impression, you send it to the lab, and then I, assess the situation. I design the partial. I make a custom tray. It goes back to you guys. Then you make the proper rest teeth and other adjustments that need to be made. Give me a final impression, and based on that, we formulate a proper fitting, cast framework. So you don't essentially even have to, survey and design the partial yourself. I mean, there's different train of thought. I mean, like working with Dr. Armstrong in the past, he was that good at doing his own designs and stuff that he basically just could take an alginate impression, and it was so precise that we made a nice Daikin impression, and based on that, I actually casted my own framework based on those impressions and those models. But it doesn't work like that for everybody. So it depends how comfortable everybody is with their impressions and their own, design of, or having an idea of what they would like for a cast partial denture, and making their own rest teeth in the areas that they would like them to be.
Sure. So one of the reasons I use historically, I haven't done partials in it's been many years since I've done this kind of dentistry as I tackle the surgical world. But when I was doing this regularly, the reason why I wanted a surveyor, I'd pour it up in Snapstone so I'd have the lab do the design, because you guys are far more qualified to provide that kind of design. But what I was finding was I would do my guide planes, for example, and I wouldn't necessarily have parallelism. So you can mark, the lab technician can mark where on the tooth, but are they perfectly parallel? And what I found over time is that they weren't perfectly parallel. They were very good. They were far better than if no guide planes were done at all. But having the ability to pour up Snapstone, which is a very fast setting stone, and then putting it on an articulator while the patient's still in the chair provides you some feedback in real time to say, are these guide planes, especially if there's multiple guide planes, are they parallel? That's hard to do. It's hard enough to, when we place implants, we place 3-4 implants next to each other to get those parallel. And we have these huge axial guide pins that are telling us exactly the axial inclination, and it's hard to get those lined up. When you have guide planes of teeth that are on different parts of the arch, it's very difficult to do. So something to consider, but I think the point I really want to drive home here is have your lab technician do the design. Absolutely have them do the design, but also communicate with them what you're willing to do. So a very good example is, are you willing to add heights of contour? So as a lab technician, Veronica, are you always assuming that the dentist is going to do reductive methods, meaning guide planes and rest seats only, or do you ever build in cingulum rests or heights of contour depending upon the design that you have, or do you do it based upon each individual doctor?
So yes, so definitely each individual doctor, everybody kind of wants something different, but I have a surveyor, so I survey my own models, and then based on my experience and my schooling over time, I just do my own design and then send it back with a custom tray to my doctor, and then they will do the preps accordingly to that design.
Do you ever
And the
do you ever build in your design rest seats with composite versus the the more conventional method of preparing the rest seat and the teeth? I'm thinking about cingulum rests on like lower canines.
Mhm. No, I don't do that. Mm-mm.
Gotcha.
I mean, it doesn't mean it can't be done. I just haven't done that.
Sure. Yeah, and that's a topic that was very hotly debated at my dental school at the time. Some of the pros members didn't like using composite because it wears, whereas others thought it was a more conservative method to add to a tooth to create an infrabulge or superbulge through the use of restorative materials rather than preparing the teeth. And that's something we'll take a look at. But understanding these kind of basic guidelines, here I put what is the minimum vertical distance from the marginal ridge of a tooth to where the guide plane should stop. These are just things that we learn about it in dental school, but it's just part of the fire hose of incoming information. There are certain bits of that water coming in through the fire hose that's actually super relevant to everyday clinical practice, and this is one of those. The guide plane has to be so tall. And you don't want to prepare so much of the tooth that you then end up involving the dentin. So this is one of those considerations. Here we have a very common clinical situation, lower molars being lingually tipped. We've talked a lot about Invisalign and orthodontics and airway. This particular clinical presentation, as we know, is very common for a variety of reasons. But this presents a problem. How is the clasp going to go on that particular tooth, this guy here, and engage without some sort of undercut created in the tooth? If the patient has an abfraction, I guess that's a natural undercut, but this particular slide was taken from modifications used to create retentive features for clasps. But we also have the addition of composite to create that height of contour so that we can engage the clasp underneath. But this is one of those situations that, a really good surveyor and a lab technician that's experienced is going to be able to help guide us tremendously. Whether or not we're putting composite on the teeth or not, lingually tipped teeth are challenging. And honestly, any tipped tooth, lingually tipped, buccally tipped, mesially tipped, so on and so forth, present a very challenging situation. I recently removed a tooth on somebody that had a severely mesialized tooth because that tooth was not going to exist in the patient's mouth with a partial. And those are difficult things to figure out over time. Veronica, do you have any thoughts on lingually tipped teeth? Are they more challenging to design? Are there things that you do or recommend in those situations?
I mean, you have to do some severe blockouts on the lingual side, I guess, because that's never going to seat. And to put a composite on the facial, I don't know how long that is going to last. So, I mean, no, I really, in that case, I'm not sure. I would just suggest that you put some locators or some attachments inside
Yeah.
the partial.
Or and we'll go over ERA attachments in the use of combination cases shortly. But sometimes crowning a tooth like that, if it's just a single tooth, crowning a tooth to reapproximate its position so that it's better suited for receiving a partial is absolutely something we could do. Obviously, composite, we're going to go over this shortly, but in a nutshell, if we use composite, there are certain composites that perform better than others. With that said, zirconia would be much better, or orthodontically moving the tooth. Although, if anybody ever does orthodontics to idealize teeth for a partial, I will send you a prize of 5 Nikkei points, whatever those are. But if we're going to use composite, make sure you understand what kind of materials you're using. You want to use a highly filled composite with a lot of glass particles to hopefully wear more slowly against the constant erosion and attrition of that partial coming on and off over time. I'm going to go back here. Was anybody here taught to use composite? If so, do you want to chime in? We don't have a super full crowd tonight, but we have three dental schools represented here tonight. I will assume nobody has used composite. I've definitely done it, and I think it's an invaluable tool for severely lingualized teeth. Lingualized canines, a situation where you have a Kennedy class 1 and the remaining teeth are 22 to 27, and the only teeth you can clasp are the lower canines, but they're lingually tipped. Composite does really good there. I don't know what else to do. Put it in the toolbox, I guess, is the only consideration. Just make sure you're using a highly filled composite. So here we have rest seat designs. I've had the conversation with several dentists over the past few years on this particular topic. You know, it's important. So when the lab technician gets this, they're making something out of metal, and there's certain space requirements that are needed for that metal to be cast, but also perform well over the long term. How do we get there? We have to make sure that we create enough space. So here we have the basic design. It's 1/3 the width of the tooth. In a nutshell, I think we understand this basic design, but where it gets a little more tricky is understanding where that prep needs to go when there's an adjacent tooth there. So this right here, maybe that's part of an RPI design, where the rest seat comes from the interproximal, and then you have an I-bar that comes around like so. But then you have the double Akers class situation where you're preparing the tooth here, and you need to make sure you create space for the lab technician to come through. So what I would encourage everybody to do, when you have this in your schedule, pull out your syllabus. I think most dental school PROS programs have really strong syllabi to lean on. If you have a textbook, definitely review this stuff. I think most of the execution done by general dentists in this arena is subpar. As somebody who's been that executor many times myself, but I tried really hard to always show up to my patients with foresight the night before. And I think this is one arena where I see many dentists showing up and they don't have a plan at all. They might have the design from the lab technician, but there's some more autonomy that needs to happen in order to create an optimal design. So on that note, Veronica, are there any things when it comes to rest seats that you see that could be improved by the average dentist?
No. I think it's just what you were just described. I think pretty much everybody understands and knows to do, to prep a rest seat and how to do it at that point. I haven't seen many issues with rest seats. Once you tell a dentist this is the rest seat needed, I haven't had issues with the depth of the preps usually.
Sure. Any thoughts? Go ahead, Chad.
Can you touch on doing rest seats like in an existing DO composite? Like what is that possible, first of all? Second of all, to what extent?
Yeah, I think.
Sorry, that's a question for me, right?
Yeah, go ahead, Veronica.
I think that's put off to Roy. Okay, I just wanted to clarify. Okay.
Yeah, so in general, percolation is the number one killer of composites. I mean, you can say the same thing about amalgams, but amalgams are more sturdy, so percolation isn't necessarily as relevant. But percolation occurs due to thermal expansion of a composite. So I guess what I'm saying is thermal expansion alone can cause a composite to prematurely fail over time. The amount of expansion and contraction that changes in temperature within the mouth caused a composite pales in comparison to the forces of mastication due to a partial sitting on it. So I don't know of any specific studies, but I've definitely been part of this particular argument in groups of dentists. And what I'll say is the dentists that think it's not a big deal almost ubiquitously are the kinds of dentists that just aren't thinking about it 10 years down the road. Those that think it's important are the ones who, track their data, their clinical performance over a decade or two. And in general, I do think that there's a pretty strong contraindication for placing a rest seat on composite due to that fact. Fast forward to the open sandwich technique, where percolation is somewhat irrelevant. So I don't think the pressure on the composite is going to cause it to debond based on mechanical forces. I think it's the micromechanical expansion and contraction of the hybrid layer over time that's going to cause it to fail. So how do we improve that situation? We use glass ionomers or resin modified glass ionomers on the dentin underneath the composite that sits underneath the rest seat. So consider an open sandwich technique if the patient is a strong, I won't say strong, but a financially conscious individual where a crown isn't necessarily in their wheelhouse. If you have to use composite, consider the open sandwich technique.
Gotcha. Thanks.
Yep. So here we have composite to create cingulum rests. So my mom is a good example of somebody that maybe had a negative outcome due to a rest seat created in her teeth. So she had the conventional rest seat made in a number 22 for a lower partial, maybe 25 years ago. She suffered from sensitivity in that tooth for many, many years. Part of that was due to a neurological condition that made her nervous system very hypersensitive. But there are times when additive procedures versus subtractive procedures are advisable. Again, composite can wear. Enamel is much better. So if we make a rest seat in the tooth, in the cingulum, yes, that's more durable over time. But I've made these and I followed these over time. I think the one that I've followed the most is maybe 7 years, and it still functions. I can't say that it's for any reason. I want everybody to add this to their toolbox, that there are times when additive procedures are better than subtractive procedures. Again, I'm talking about rest seats and rests on lower anterior teeth predominantly. But this is a particular image showing what needs to happen. We just have to create a platform for the partial to sit on so that the axial of force is down the long axis of the tooth. If it's not down the long axis of the tooth, it destabilizes. It activates the osteoclasts and osteoblasts. That's what happens when we're moving teeth, when we're doing orthodontics. So partial, under all circumstances, should exert forces axially down the long axis of the tooth. If there's any rotation component to it, then it definitely destabilizes the periodontium and can cause vertical bone defects, bone loss, mobility, so on and so forth. So it's pretty obvious here. Indirect retainers. I think indirect retainers is one of those terms that, again, it was probably on one exam that we had in second year dental school. Once we passed that exam, we never thought of it again. But I think it's an important clinical concept because it shows up in a lot of other areas of dentistry, whether it's doing balanced occlusion in dentures or all-on-4 full arch prostheses. Indirect retention shows up quite often. So it's a concept that we should understand. And basically, it just says that when we're biting down on one end of the fulcrum line created through a line connecting the most distal teeth, essentially when we apply pressure distal to that line, we have indirect retention on the other side of that. And that concept of cross arch stabilization is very important. So I said pressure down here, pressure to the tissue. It's actually retention. So it's indirect retention, meaning if this wants to lift up due to any sort of extrusive force to the prosthesis, it's supported by that indirect retainer here. That indirect retainer needs to have support, and that's where that composite sometimes comes in handy. So lessons from the field. These are things that have popped up on my radar over the past few years with respect to partial dentures. Evaluate the existing situation. So all too often when we're treatment planning, we see a patient who has missing teeth, they want something there, and then we just try to fill it. But evaluating the environment at which we're going to be building in is very important. Again, obvious, but I sometimes, at least in my own clinical practice, the obvious things tend to take the back seat. So looking for things like tilted teeth, the perio and caries risk has to be part of this overall treatment planning process. The patient expectations, again, going back to that patient I talked about on slide 1, this took me a long time to get, and it's still something I struggle with. Making sure that the patients understand that they're getting a cost-conscious option only. That's it. Nobody would choose a partial over implants for any reason other than cost. And maybe there are exceptions to that, but I think 9 times out of 10 that comment would be true. Consider crowns to improve the foundation and improve clinical performance. So this is what we term combination cases. It's hard when a patient is cost conscious to get them to choose a crown, but I can tell you that when we do crowns, even a single crown on an arch to improve the fit of a partial, it makes our life so much easier. So when you can, really advocate for a patient to consider crowns. Don't take the patient saying, I can't afford much, for the reason to not offer this. The difference between a partial without a crown, especially with certain lingualized teeth, and the execution of using crowns to improve the clinical performance is rather profound much of the time. And the cost difference to the patient is sometimes doable. And then lastly, obtain a design before final impression day. Veronica went over that. So it's a very important fact that, busy practices, we forget to send the impression out for the design, the patient's in the schedule, and all of a sudden we're patient's in the chair and we're looking at the teeth and you have no idea what to do. I see it happen very often. This is something that I want to be a takeaway message as we have a conversation about lessons from the field. So this is fix pros to improve clinical performance. This is the concept of combination cases. Combination meaning a combination of fixed and removable. So let's have a quick conversation. What can crowns do for our partials? Well, first, they can improve the structural integrity of the abutment teeth. This comes back to Chad's point. Can we put partials on teeth with composites? Well, I think we had that discussion in good detail, but sometimes the teeth are just structurally unsound and really shouldn't be clasped and supported on, because of the fact that most of the crown structure is a foreign material and not necessarily natural tooth structure. So improving that structural integrity of the abutment teeth is a very important part of combination cases. But we can also improve the heights of contours of partials. And we talked about lingualized teeth. Chad, I'm thinking back to Beth, a case that we went over a couple months ago. When teeth are lingually tipped, getting them to perform well clinically is challenging. And we have to think about our prep designs. In your particular situation, it was a prep design for a fixed partial denture, but we had to think about it. When it comes to partials, sometimes we have to use crowns to upright the teeth so that we can get a height of contour for proper retention. Again, very obvious stuff, but very much overlooked in everyday clinical practice. It can also improve the biomechanics of the partial. It improves the fit dramatically. The best fitting partials I've ever done are on combination cases that I've done, because the crowns were optimized to receive a future partial. And then lastly, these things are made through surveying, so asking for a surveyed crown from the lab so that the future partial will fit optimally. Veronica, do you have any points on combination cases using fixed prosthodontics to improve the fit? And we'll talk about ERA attachments and things like that, but I'm just talking about single unit crowns at this point.
Pretty much what you said is right on. It's pretty precise.
Great.
I don't think I have any more to add to that.
Great. One thing I see, and Veronica, this is partly a question for you. I was taught in dental school that the clasp tip should be the engaging part of a crown, and I see there's a space here.
Mm-hmm.
I find it very difficult when they're not engaging, because what that means is that there's a lot of interferences here. They never really fit well. So when they're cast, the lab technician, my guess is, has to be rather skilled to make sure that the clasp tip is the engaging part, and then you have a very minute space of passivity between the clasp and the tooth itself. But oftentimes I see this. Is that a hard thing to do? I know you don't cast your own frameworks anymore, but you used to, right?
I used to, and I did not do that. I mean, I you can always, for some reason, like with the metal that I'm using or that my person is using, it's easy to adjust with pliers, so you can bend the clasp easily.
Sure.
I've never done the lifted clasp like that at the end, at the tips myself.
Yep.
So again, it's if somebody wants that and requests it, you can definitely do it. I just have not, I haven't seen it with my frameworks, my doctors, and my casting guys. So
Yeah, I mean, I've been your frameworks to this day are still the best frameworks I've ever used. But this is not something I've seen necessarily with you, where there's like a large gap here. Like
no, because it also has to irritate the patient. I'm sure they're like, I mean, that
sure.
not getting and lifted, that's got to be, irritating them, and yeah. So no, I have not. I'm surprised it looks like that, but
Yeah. Can you speak a little bit about why you don't cast anymore and why you use somebody else? I think that's an important point for us to understand clinically.
so I used to cast my own frameworks when I worked in the lab for somebody else, and I had the time to do it. But now I have to focus on what's, on certain things, and financially, it just makes no sense for me to wax and cast my own frameworks and do the finishing work because that just takes so long. It's just it makes it doesn't make sense for me
Yeah.
as one single as a one single person lab or studio. So that's why the gentleman that I'm using, I've used him since 2006, and they do beautiful work, and we never have any issues with fits. So I don't see the reason why I would do my own. Plus, I really don't love doing metal work. So
Yeah.
yeah.
I think knowing what's on the other side of the lab world has been hugely beneficial for me, chair side. So those out there, if you ever have downtime, schedule a time to go hang out with your lab technician. I promise you're going to become a better dentist. I mean, it's one of the there's like two low hanging fruit in our career. One of them is go visit your lab. I don't know, however many times that you see it being beneficial.
Yes, come visit me. I get lonely.
A beautiful spot too, right above Gritty's in Portland. The other is doing endo on extracted teeth. It's single-handedly the best thing you could possibly do if you do endo is to do something so simple. So sometimes the things that make us better are not more reps, but it's just insight through something outside of the normal clinical practice. So adjusting metal frames, if you use Veronica, you don't have to do any of this because they fit so well. And I'm being somewhat facetious, but I'm not. But there are times we have to adjust. And I was taught to use GC Fit Checker, which is a silicone-based catalyst mixture, which is very cumbersome and time-consuming, messy, and expensive. So I started using Occlude Spray. Many of you probably already use this, but I can't speak to it enough. Occlude Spray for the metal framework part of adjusting is a game changer. You can see the certain areas of the rest seat, guide planes and rest seats that are potentially binding the clasps, adjusting so on and so forth. And then all of the acrylic using your conventional PIP paste. Anybody have any thoughts or comments about adjusting? This does seem to be a sticking point for young dentists, so I thought I'd put it in here. Basic workflow, but very important to know. How do you get the Occlude Spray off? Jewelry cleaner. So if you don't have a steam cleaner in your office, this is by far one of the best things to have. If you ever need to clean anything using a steam cleaner, I think I'll just leave this here. I think most of us know this. Labs use them all the time because they need to clean after various steps. But we have found this very invaluable in our practice. Currently, it's been down for a couple months and nobody's been squawking, so it hasn't been repaired yet. But when I'm doing a lot of removable work, I can't live without a steam cleaner that's on in the lab so that I can clean stuff as I move forward throughout the day. All right, the all acrylic partial. Let's see what time we got. It's already 7:50. You got to be kidding me, man. All right. I'm going to skip over this and just quickly go over to the Valplast conversation. Veronica, I know you only do more of the conventional all acrylic partials in great part because Valplast is a system that is typically not done by your particular client base of dentists. I think most of the dentists you work with are using metal for good reason. But this,
Or but I do on occasion the Vaplast partials, and it's usually in the case of patient having allergy reaction to monomer.
sure.
But it's so I get the partial done all the way to the final step of a trying or set the teeth, and then I send it to my lab to just process the Valplast part of it. But literally, probably do maybe 4 of these a year.
Sure.
That's why I own the system, because I don't have, the high demand. And I know a lot of dentists would send it to Glidewell for processing because of the, it was cheaper, and, they were doing it on daily basis. So
Sure.
it depends. But yeah, I mean,
Yeah,
So-
this topic comes up a lot, and it was one that I don't know, for a couple of years I don't think I fully understood. I'm going to hopefully hit the high points here really fast. So, in a nutshell, there are several versions of the Valplast family: Duraflex, Valplast, and TCS materials. These are the three that are offered by Glidewell. Many labs have their version of this. The important thing to understand is it's not a monomer based. It's not methacrylate based. So patients often have a methacrylate allergy. These come in handy when those certain circumstances exist. Likewise, nickel allergies. So metal frameworks sometimes have certain parts of their alloy that produce some sort of allergic reaction. So there are times that these are relevant, but let's have a conversation about these real quick. What are the pros? Well, they're lower cost. The lack of metal really allows these things to be super cheap. Patients sometimes say they're more comfortable, they fit more like a glove, they're non-allergenic, they're unbreakable much of the time because they're made out of thermoplastic nylon, which is basically just unbreakable. Sometimes relatively higher aesthetics because of the absence of metal clasps. But here are the cons. So they're temporary in nature. They tend to absorb moisture over time, so they can get pretty nasty. They could become sources of bacterial infiltration, so on and so forth. Valplast is non-repairable. This is one of the big things. So if you need to add or subtract something, you really can't. It's not acrylic where you can add or subtract very easily. So really, it's cheaper and faster just to make a new Valplast partial. So the non-repairable. The Duraflex partial does have the ability to be modified, but you have to understand that some of these within this class are not necessarily repairable or relineable. This is the most important part right here. So there are no vertical stops. So with a metal framework, you have occlusal rest seats. What's holding up a Valplast partial is the tissue. So you're more likely to have tissue sores. I will say that of the, 10 or 15 of these I've done over my career, I've had a few sores, but I've had sores with other partials, so I don't want to say this is necessarily a reason not to do it. But in a nutshell, it's applying more pressure to the tissues, and in a nutshell, it's applying more pressure to thin biotypes. So Valplast, to me, are contraindicated for certain periodontal biotypes. So just kind of keep that in mind when you're choosing a partial. Sometimes you want to choose a tooth-borne partial based on the fact that their periodontium is of high risk. Last thing you want to do is induce recession because you're trying to save the patient money. They can be bulkier, and they're contraindicated for Kennedy Class 1 cases with thin ridges. So keep that in mind. Always work with your lab. Say, hey, this is what I'm trying to do. What do you think? A lot of insight can come out of that. We talked about this.
Many doctors calling it
I'm going to skip that. So recently I did an acetyl resin RPD, and Veronica, I was at your lab recently, and you had one of these milled. Are you doing this now?
I am not doing them yet. The system among Gerbach, they have not really approved them yet for me to be milling them here. So I'm just waiting for my rep to kind of say, you can go ahead and do it.
Give you the green light.
Yeah.
Yeah, so I've done a few of these with Glidewell. Oddly enough, saw one of the patients today for something unrelated. She had an implant on the lower that was bleeding, but I did an upper partial for her. Her clinical circumstances required that I do this. There was no other solution that was going to fit her other than a valplast, and I really didn't want to go with a valplast for her because she has a thin biotype. So this does have a lot of the benefits of a metal framework, but it's somewhat flexible and very aesthetic. So one of the nice things that this is probably milled from an acetyl puck. Therefore, you can choose different shades. So these clasps can be milled from the Vita Classic Shade Guide or whatever shade guide you use. So they can be rather aesthetic. I don't want to say it's invisible, but it's definitely better than a metal clasp when in the interior section. But I don't know. It doesn't have the satisfaction of fit that I get with a metal framework. So they're not the same, at least in my hands so far. Again, I'm working with Glidewell, so there's limitations potentially there. But adjusting the clasp is done by, as they say, heating it. And I asked them at what temperature, what kind of flame, and they're like, you just heat it. And I'm like, you're not answering my question. It's pretty tricky. I was able to adjust it with some heat. I overburnt one of them once upon a time. I think the first or second that I did. So there is a learning curve with this. So if you're going to choose to do this, I recommend choosing the right patient and maybe do both at the same time. Let the patient have both. Use it as a learning experience. I would not try to pull this off. To me, in my hands, that this is different enough that it's probably not going to go well. That's just my hunch. With that said, this is probably the future. You know, with milling and 3D printing, I think really metal's probably, I don't know, going to lose its market share to some degree. I don't want to say it's going to become obsolete. So acetyl resin, RPDs. Veronica, the moment you get your green light, let's do a case together. I'd love to do one with you.
Oh, that sounds great. Thank you. Thank you.
Yeah. The other thing is Bruxers, because the rest seats are likely to wear compared to metal, are contraindicated because you lose the rest seats over time. All right, so here's a checklist. We went over a lot of this. The point is, have a workflow for your partials. Send it to the lab, get your design, make sure that you have a process so you're not ending up having a patient in the chair waiting for you to get the final impression and you really have no idea what you're doing. Super obvious, but I see it day in and day out. We talked about this. Veronica, I would like to talk about this. In a nutshell, when you have to do a crown underneath an existing partial, there are several options. The first one is you send the partial with the case. This often is not possible because the patient won't let you send it. That is the best option by far. Would you agree to that?
Yes.
Yeah, but often not possible.
Right.
Method number 2 is the sandwich impression of the prep and the partial in place. That's what this particular image is showing here. In the mouth, so this is on a model, but in the mouth you would do this where you seat the partial and then you inject. I think it's important to not inject light body like they're doing here because light body is not stiff enough. You really want to use a like Regisil, like a bite registration material that's stiffer. At least that's what I've been told by the labs. But there's a third method, which is to copy the existing pre-op. So if the tooth that you're prepping is currently interacting with the partial, just take a preoperative impression. I learned this by putting this presentation together. I'd never heard of that before. Then they can copy mill the existing crown. I say copy mill. Now it's done digitally where they digitally stitch the two together to create the ideal crown that goes underneath it. Now, if the tooth is broken or it's lost its intimacy to the clasp, you can build it up intraorally. And I've done that before, not for this purpose, but I've definitely done build-ups underneath existing clasps because the patient couldn't afford a crown. I can share that particular method at a later point in time if anybody's interested. I actually have some photos of it. But in a nutshell, you can use the pre-existing crown form, just take an impression and send it to the lab with the prep model. So you'll have two models, the pre-op and the prep model. But Veronica, you brought up a good point. So can you talk a little bit more at the beginning? You were saying that with digital scanning, what are the series of scans we would take so that you have all the information you need?
So if you're going to be using a scanner, which is really ideal because then we can, the more scans you send me, the better. Then I can see them together on a computer. So I would say a scan of the prep, scan of the integral of the partial, the clasp, then the opposing, the bite, how this partial fits, and that should really be about it.
Beautiful. What about the partial on the teeth?
Yes, so partial on and off. So scan of the partial from different angles outside of the patient's mouth, and then scan in the patient's mouth with the partial in.
Beautiful. Love it. I mean, we've been doing the analog method for a long time, and every time I've talked to the lab, they're like, "Oh, this is so hard." They'd use like GC pattern resin to create a replica on the model. It worked, but it wasn't very accurate. From what it sounds like, you've had great success with this. Yeah, so can't wait to do that. We've had, I don't know, 3 of these in the past month or two. So I'd imagine we'll have one coming pretty soon where we can stitch the two together and get a really good crown. Anybody have any thoughts or questions about this particular clinical situation for Veronica? Great. You know what? We're just going to keep going. I think this is a cool old school technique that I learned from Dan Armstrong. I remember reading about it in dental school. Never really did anything with it. And then Dan talked about it in a lecture once. And then I was working with you, Veronica, back in, 2016, 2017. And I was like, hey, can we do one of these together? So you and I did, 3 of these. Absolutely amazing fit. So the idea is the following. For Kennedy Class 1 distal extension cases. So if anybody's still awake, try to follow me here.
Altered cast, yeah.
Altered cast. So the impression materials that we use have different pros and cons depending upon the entity at which we're trying to capture. Alginate does really good on soft tissue. It does a pretty good job on teeth, but it doesn't do as good as PVS on teeth. Conversely, PVS does really good with light body, heavy body, capturing the intricacies of natural teeth, but because of its higher viscosity, it doesn't necessarily capture tissue very well. So this altered cast method basically uses the benefits of both of those worlds so that you have a partial denture that fits really good on the teeth with the metal framework, but then the saddles on the distal extension area account for the compressibility of soft tissue. There's a reason why these particular partials tend to be most loose, and it's because of the fact we're using one impression material. So here's the workflow. We take a PVS impression, so the lab technician can make a metal framework. The lab technician will also put on the metal framework these saddles. In this case here, it looks like green stick compound, or really, I don't know, Veronica, I think you just used Triad. It doesn't really matter, but something to capture a distal extension impression. So it's almost like this is a custom tray.
It looks like you or somebody else, I don't know whose case this is, but somebody else border molded the saddles that you send to make it more accurate.
Gotcha.
So
yeah, I just pulled this off the internet. This is, but yeah, I mean, in essence, it's like 2 saddle custom trays on the distal extension that the lab puts on. So you try the framework in, you make any adjustments on the framework, and then you take another impression with alginate, or I actually like tissue conditioner. Tissue conditioner is, I'm really going off on a tangent here. Tissue conditioner accounts for the difference of tissue thicknesses on a ridge, where you might have thin tissue in one area and thicker in another. It kind of equilibrates that. And if you don't know the concept I'm talking about, it's a pretty important concept. It has to do with conditioning the tissues for complete dentures after healing, denture source, so on and so forth. But tissue conditioners, Co-Comfort is what I use for this. Works really well. So then the lab fabricates the final altered model. So this is the workflow here. Diagnostic cast, custom tray, final impression with PVS to capture the teeth. Here's the final model. The framework is then fabricated. with that distal. This is not a very good picture of it, but it's essentially a custom tray on just this section. This is what it looks like on the underside, so the intaglio. An impression is made in the patient's mouth of this right here. I guess, no, this actually is the final impression. So framework try-in with the final impression. This is the altered cast. So what the lab technician does is they cut the model. This was the PVS impression, and then this is the alginate or the tissue conditioner impression. It's a very accurate impression using two different kinds of impression materials to make a master model. I can't even tell you how amazing these fit. Veronica, it's been a while. We should do one together very soon. So if any of the doctors that are on the call from the practice, if you have a distal extension case, let's do this together. I'd love to do it, and Veronica's very good at doing this because she did it with Dan. Is it overkill?
You can document it too if you want to do one. We can have a cool case to take good photos on.
Absolutely, yeah. The first time I delivered one of these cases, the thought I had in my head was the following: this is as stable as an implant, fixed implant prosthesis. That's how stable it was. Never delivered a partial where I had that kind of thought. So it was more stable than an overdenture with locators. All right, last slide here. We talked a little bit about ERA styled combination cases. This was very popular in the 70s and 80s. Unfortunately, here's the problem with this. They're very expensive to do. They're very technique sensitive. And the moment you get decay underneath one of these teeth, the whole thing needs to be redone. So I've done 3 of them in my career. 2 of them got decayed within 5 years. The final one is still in the patient's mouth as far as I know. I think I saw her 2 years ago. But there's a reason why we don't see these cases anymore. It really creates a lot of food traps, and the root surfaces underneath these crowns are at very high risk for root surface decay. The torquing forces on the teeth can cause instability. In a prosthodontist's hands with proper patient home care, maybe, but for a general dental practitioner that does one of these a year, very difficult. Veronica, I don't know how you feel about these. I just went on a tirade about how much.
I mean, I've only, I've only seen these maybe once or twice in my life, and that was at dance practice that like years and years ago.
Yeah.
I haven't really done one of these. I haven't seen them recently. It's just outdated.
Yeah, I mean, now that we have implants, putting 2 implants distal to those distal teeth, you're going to get the same outcome, but you're not necessarily stressing the teeth at the same time. So, Stern Gold made these in the 70s and 80s. It was a very big part of dental education for a couple decades, but it's not necessarily relevant anymore. With that said, maybe for a bisphosphonate patient that really wants something fixed and doesn't want clasp, I mean, there might be a place for this. With that said, we went over a little bit. Patient selection we talked about. There's a consent form here. I'm happy to share this with anybody. I'm just going to leave this right here. You can hit pause if you want to watch the video. I basically created as many shitty things that happen during partials, and you really should have a conversation with the patient for each one of them and have them initial. I don't do this, but I will as I put this together. I think about this as I'm driving home after a really shitty day because a patient was really upset with their partial that I have remade 3 times and they're upset with. These are realities of removable prosthodontics that I think we're all very aware of. But a proper consent form and having the patient sign on to the downsides is the best thing you can do. Again, I'm going to listen to my own advice here in the next couple of days and put this into our growing consent form library. So that's pretty much it, I think. There's Veronica. Thank you, Veronica.
Yes, during the day.
What's that?
That's me during the day.
That's you during the day. Yes.
Look very differently right now. Sorry, guys.
All right. Anybody have any thoughts, questions? The goal of tonight was hopefully to hit the high points of partials. Partials are tough to do well, and they require some homework. But the best thing you can do is find a lab technician that knows how to do them well create a relationship with them, get them on your Rolodex, and communicate. Have them be part of the design process so that you're not just taking impressions of teeth and sending it to the lab and hoping for the best. All right. Very good. Veronica, if you want to stay on, I know you and I had a few follow-up items, but everybody have a good night. And